Diabetes pharmacology has changed more in 10 years than in the previous 50. Think about that for a second. We've got SGLT2 inhibitors that are quite literally protecting hearts and kidneys. We've got GLP-1 receptor agonists that have exploded into some of the most talked about drugs in the entire world. The way we manage type 2 diabetes has been completely transformed from the ground up. And honestly, we need to understand not just how these drugs lower blood sugar, but exactly why they are drastically changing outcomes for millions of patients. Today, we're giving you the complete picture, every major class. Let's get right into it. Welcome to this Explainer. It's absolutely fascinating to look at this massive shift in medicine, moving from just trying to lower numbers on a lab report to actually protecting the whole patient. Let's dive into the complete picture of every major diabetes drug class and break down all this complex pharmacology into something incredibly clear, practical, and applicable.
Here's our roadmap for today. We'll start with the core targets, check in on the classics, dive deep into SGLT2 inhibitors and the GLP-1 phenomenon, touch on other essential classes, and finally, wrap it all together with the modern decision framework.
All right, section 1, core targets. Let's make sure we clearly understand the baseline diseases we're actually treating here. So you probably know type 1 and type 2 diabetes are fundamentally different diseases, right? Type 1 is an autoimmune condition. The body's immune system goes rogue and mistakenly destroys its own beta cells in the pancreas, the exact cells that produce insulin. The result? Little to absolutely zero insulin production. That means insulin replacement is required for life. There's just no oral medication that can magically fix this. Type 2 diabetes, though, is a completely different story. It typically kicks off with insulin resistance. The body's cells just stop responding normally to insulin. So what happens? The pancreas tries to compensate by pumping out even more. But over time, it just can't keep up the pace, which leads to a progressive decline in beta cell function, which leaves us with this crucial rule of thumb. Type 1 equals insulin replacement always. Type 2 equals multiple mechanisms, often combined. And this physiological distinction dictates literally the entire landscape of drug therapy we're going to talk about today. Almost every oral diabetes medication works by improving insulin sensitivity, ramping up insulin secretion, or changing how glucose is absorbed or excreted. None of those mechanisms are going to help a patient whose pancreas produces essentially no insulin at all. And that right there is exactly why type 2 diabetes has this massive, fascinating landscape of treatment options we're about to explore.
Moving on to section 2, the classics, good old metformin and insulin.
Let's start with metformin. It's been used clinically since the 1950s. In a field with so much rapid-fire innovation, that kind of longevity is honestly astonishing. It primarily works by reducing hepatic glucose production. Basically, it stops the liver from dumping excess glucose into the bloodstream. And there are huge reasons why it remains the first-line choice globally. It's highly effective, it's weight neutral, or it might even promote modest weight loss. It carries a very low risk of hypoglycemia because it doesn't artificially stimulate insulin secretion. It has proven cardiovascular benefits, and as a bonus, it is incredibly inexpensive.
Now here's a massive clinical pharmacy counseling point for you. Gastrointestinal upset is the single most common reason patients just abandon their metformin altogether. But if you start them at a low dose, tell them to take it with food, and titrate it up slowly over several weeks, most patients tolerate it perfectly fine. That proper counseling literally keeps patients on this crucial drug. Also, it's absolutely vital to monitor their eGFR. Metformin is cleared by the kidneys, right? So in severe renal impairment, it can accumulate and trigger a rare but very serious condition called lactic acidosis. Let's look at insulin. We generally classify it by onset and duration. It's like having different tools in a toolbox. Rapid acting kicks in fast, within 10 to 15 minutes, specifically to cover a meal. Short acting takes about 30 minutes. Intermediate acting takes 1 to 2 hours to start working, but lasts up to 18 hours. And then we have our long-acting insulins, which are great because they provide this relatively flat, steady background effect that lasts 18 to 24 hours or even longer without a pronounced peak. So how do we tie all those timings together? That brings us to the basal-bolus regimen. This is a strategy where you combine a long-acting background or basal insulin with a rapid-acting bolus insulin at mealtimes. This setup is brilliant because it perfectly mimics how a healthy pancreas actually operates, making it the gold standard regimen. But with insulin comes the single most important counseling point in all of diabetes care, hypoglycemia. Patients absolutely must be taught to recognize symptoms like sweating, tremors, and confusion. And more importantly, they need to know to treat it immediately with fast-acting carbohydrates to prevent life-threatening emergencies. All right, section 3, SGLT2 inhibitors. This is where we go way beyond just blood sugar. This class has a frankly elegant mechanism, and it's happening right in the kidneys. Basically, step 1, It blocks the SGLT2 transporter, which normally reabsorbs glucose back into the blood. Step 2, because it's blocked, the glucose stays trapped in the urine. Step 3, it's literally excreted right out of the body when the patient urinates. And step 4, blood glucose naturally drops. What is so brilliant about this is that it's completely insulin independent. It works regardless of how insulin resistant the patient happens to be. And here's where the story gets really wild. During the clinical trials for SGLT2 inhibitors, which, by the way, were initially just designed to prove they were safe for blood sugar control, researchers found something totally unexpected. Patients were suddenly having significantly fewer hospitalizations for heart failure, and their kidney outcomes were vastly improved, completely independent of their blood sugar levels. As the quote goes, a diabetes drug became a heart failure drug and a kidney protection drug. And that almost never happens in medicine. It was a real game changer. So today, SGLT2s are officially prescribed for type 2 diabetes, heart failure, and chronic kidney disease, sometimes even in patients who don't have diabetes at all. But we definitely have to counsel on the side effects. Because you are constantly passing glucose through the urinary tract, it acts as a food source for bacteria and yeast, which increases the risk of genital mycotic infections and UTIs. And most crucially, we have to watch for euglycemic DKA. This is a hidden, tricky danger where a patient can go into diabetic ketoacidosis even when their blood glucose levels appear completely normal or just mildly elevated. Which brings us to section 4, the GLP-1 phenomenon. The drug's making literally all the headlines right now. To really understand what all the fuss is about, we first need to define GLP-1 itself. It's an incretin, which is a natural hormone released from your gut right after eating. And it does 4 amazing things. First, it increases insulin release, but only when glucose is high, keeping the risk of hypoglycemia super low. Second, it decreases glucagon. Third, it slows down gastric emptying, keeping you feeling full for a lot longer. And fourth, it acts directly on the appetite centers in your brain to just reduce hunger. Drugs like Semaglutide are synthetic agonists specifically designed to mimic and prolong these exact natural effects. Think about it like this. A drug that improves blood glucose and produces significant weight loss is addressing 2 interconnected problems simultaneously. Excess weight is a massive, massive driver of insulin resistance in type 2 diabetes. So the weight loss we're seeing here, which is often 10 to 15% of a patient's body weight, isn't just some cosmetic side effect, it's a profound clinical benefit that tackles the root cause of the insulin resistance itself. And the benefits don't even stop at weight loss. There are major cardiovascular benefits here, with several of these drugs actually proven to reduce heart attacks and strokes. Now, for side effects, the main ones you need to counsel patients on are GI symptoms, things like nausea and vomiting. The good news is, these usually improve if you just titrate the dose slowly. We also keep an eye out for a rare risk of pancreatitis. And, importantly, there is a strict contraindication for patients with a personal or family history of medullary thyroid carcinoma, which is based on findings from animal studies. Moving right along to section 5, other essential classes. We're talking DPP-4s, sulfonylureas, and TZDs. Let's quickly compare these remaining tools in the toolkit. First, we have DPP-4 inhibitors. These block the enzyme that breaks down your body's natural GLP-1. The effect is modest, sure, but they are very well tolerated and totally weight neutral. Next up, sulfonylureas. These basically force the pancreas to release insulin regardless of what your blood sugar levels are doing. Because of this, they can cause weight gain and carry a high risk of hypoglycemia. They're still popular globally, though, mostly because they are extremely inexpensive. Finally, TZDs. These improve insulin sensitivity in fat tissue. They won't cause hypoglycemia on their own, but they are notorious for causing fluid retention, which means they are strictly contraindicated in patients with heart failure. Listen, I need to pause for a critical counseling alert here. This is so important. Because sulfonylureas force the pancreas to secrete insulin no matter what, if a patient takes their medication and then decides to skip a meal, their blood sugar will absolutely crash. This is a completely preventable cause of severe emergency department admissions. Literally, a simple conversation at the pharmacy counter about maintaining regular meal timing can save lives. All right, section 6, modern decision framework. How do we actually choose? So how do we put this all together for an individual patient? Well, step 1, metformin is still almost always first line unless there's a specific contraindication. Step 2 is where modern medicine truly shines. We evaluate comorbidities. If a patient has heart failure, cardiovascular disease, or kidney disease, we immediately reach for an SGLT2 inhibitor or GLP-1 with proven organ benefits, regardless of their current blood sugar. Step 3, we consider weight priorities. If weight loss is essential, we're going to prefer GLP-1s or SGLT2s over things like sulfonylureas or insulin. And finally, step 4,
we assess hypoglycemia risk. If a patient is elderly, frail, or say they drive for a living, we actively avoid any drugs that can cause a dangerous drop in blood sugar. We have completely moved from an era of merely trying to lower the number on an HbA1c test to this incredible new era where we actively protect the whole patient